gluteal region goes by many names and nicknames in the cosmopolitan world.
Anatomically, the gluteal region lies posterior to the half of the pelvis. It extends from the iliac crest above to the gluteal fold below, mid-dorsal line, and natal cleft medially, and is limited laterally by an imaginary line joining the anterior superior iliac spine to the anterior margin of the greater trochanter. The natal cleft is the space between the two halves on the buttocks where the anus lies.
Aside from the role of the gluteal region in gait and posture, it is an area of immense attention in the cosmopolitan world as cosmetic surgeries involving the gluteal region is gradually on the rise. The popular BBL surgery, which we still discuss.
Let's discuss the layers of the gluteal region from outer to inner. The skin is the outermost part. For anatomical description and clinical relevance, each half of the gluteal region is divided into 4 quadrants. An imaginary vertical line is drawn from the upper margin of the hip bone through the middle of one gluteal half to the lower gluteal fold. Another imaginary horizontal line is then drawn to cross this vertical line at the middle. This gives us the 4 quadrants. The upper outer or superolateral quadrant, the safest area for intramuscular injection. The upper inner or superomedial quadrant, superior gluteal damage is prone to injury by intramuscular injection, although this is rare. The lower outer inferolateral quadrant, injection into this area would damage the sciatic nerve, the inferior gluteal nerve and vessels, the posterior cutaneous nerve of the thigh. The lower inner or inferomedial quadrant, injection into this area may damage the sciatic nerve, posterior cutaneous nerve of the thigh, the pudendal nerve and vessels, and the inferior gluteal artery. Remember, the upper outer quadrant is the safest zone. All other quadrants must be avoided. Next to the skin is the superficial or subcutaneous fatty layer. This is the layer that gives the gluteal region its wide recognition in society. It is the layer responsible for the size, projection, and shape of the buttocks due to its huge deposition of fat. Without being biased, you agree with me that your attention will be drawn to a big butt lady more than one with the opposite. The difference in size is due to the volume of fat in this superficial layer, which is predominantly genetically determined, but may be modified by other factors. This layer of fat is also the layer that is operated on during cosmetic surgeries, like the BBL, to give a lady her desired butt outlook. Deep to the subcutaneous fat layer is the deep fascia. The deep fascia of the gluteal region encloses the 2 most superficial muscles of the gluteal region, the gluteus maximus and the tensor fascia lata. Between these 2 muscles and the region of the upper outer quadrant, it forms a condensation called gluteal aponeurosis over the underlying gluteus medius muscle. Since the area is not covered by gluteus maximus, it implies that an intramuscular injection in the upper outer quadrant does not pass through the gluteus maximus muscle.
Before we discuss the gluteal muscles, let us do a quick overview of the hip bone. This is the right hip bone. On the outer surface of the ilium lies 3 prominent features: the posterior gluteal line, the anterior gluteal line, and the inferior gluteal lines. Take note of these features as they are important in understanding the attachments of gluteal muscles. Here lies the greater sciatic notch, the ischial spine, and the lesser sciatic notch. Here lies the ischial tuberosity, which is a very important prominence which we sit on. There are 2 ligaments on the posterior margins of the hip bone. The sacrotuberous ligament originates from the lower sacrum, coccyx, and posterior ilium to insert on the ischial tuberosity. The sacrospinous ligament connects the ischial spine to the lateral margins of the sacrum and coccyx tailbone. The 2 ligaments intersect to convert the greater and lesser sciatic notch into foramina in the human body. The greater sciatic notch becomes the greater sciatic foramen. The lesser sciatic notch becomes the lesser sciatic foramen. Let's now discuss the muscles of the gluteal region.
For simplicity, we divide them into two groups. The superficial group, the deep group, 4 muscles in the superficial group, the gluteus maximus, the gluteus medius, the gluteus minimus, the tensor fascia lata. By now, you are already familiar with the gluteus maximus and the tensor fascia lata, which featured during the discussion on the deep fascia. Largest, most superficial and quadrilateral in shape, it arises from the posterior gluteal line of the ilium, the dorsal surfaces of the sacrum and coccyx, and the sacrotuberous ligament. Most of this muscle's fibers insert in the iliotibial tract, but some fibers from its lower half attach to the gluteal tuberosity of the femur. It is innervated by the inferior gluteal nerve. Although it is used in standing and walking, it is most important as a powerful extensor at the hip when the trunk is being raised from the flexed position, like when rising from a sitting position or in climbing stairs. Next is the gluteus medius. Remember, we already established that the gluteus medius is covered by a condensation of deep fascia called the gluteal aponeurosis. If you clear the gluteal aponeurosis, you will see the gluteus medius. If you bisect the rectangular gluteus maximus, you will see the full gluteus medius muscle. The gluteus medius muscle, a broad, thick, fan-shaped muscle. It originates external surface of the ilium between the anterior and posterior gluteal lines, inserts into the greater trochanter of the femur. Deep to the gluteus medius is the gluteus minimus, which shares lots of similarities with the gluteus medius. Of course, aside from their different names, and the fact that the gluteus minimus lies deep to the gluteus medius, you will also have to replace this posterior here with inferior. Thus, while the gluteus medius originates from external surface of the ilium between the anterior and posterior gluteal lines, the origin of gluteus minimus is between the anterior and inferior gluteal lines. These two muscles insert on the greater trochanter. Both are innervated by the superior gluteal nerve, and both will abduct and medially rotate the thigh at hip joint. Although the gluteus medius is the chief abductor, minimus acts like the deputy abductor. They also steady the pelvis on the leg when the opposite leg is raised off the ground. For example, while the left limb is off the ground, the gluteus medius and minimus of the right side steady the weight of the left limb on the right pelvis. Thus, left steadies right, right steadies left. This happens in quick alternate pattern during the gait cycle.
A damage to the superior gluteal nerve on one side would result in paralysis of gluteus medius and minimus of that side, resulting in loss of steadiness or stability of the contralateral limb, and is marked by limb shortening and pelvic drop. This is called the Trendelenburg gait. Thus, a right superior gluteal nerve damage results in left pelvic drop or left limb shortening, and vice versa.
The tensor fascia lata arises from the anterior superior iliac spine and the anterior portion of the iliac crest. As the name implies, it inserts into the iliotibial tract, which then inserts on the lateral condyle of the tibia. It is also innervated by the superior gluteal nerve. It flexes, abducts, and medially rotates the thigh at the hip. With the assistance of the gluteus maximus, this muscle stabilizes the hip joint. The muscle also stabilizes the extended knee.
Remember this mnemonic. Max. Goes. Down. Gluteus maximus is supplied by inferior gluteal nerve.
The muscles of the deep group are the piriformis, the superior gemellus, inferior gemellus, obturator internus. All three known as the triceps coxae, the quadratus femoris. All five muscles are lateral rotators of the hip. The piriformis is a pyramid-shaped muscle. It arises within the pelvis from the anterior surface of the second, third, and fourth sacral segments and the sacrotuberous ligament. It passes through the greater sciatic foramen to insert on the greater trochanter of the femur. During anatomy dissection, it usually lies immediately above the sciatic nerve, although the nerve may pass through it in rare cases. Innervation is via the ventral rami of first and second sacral nerves. The piriformis abducts the flexed thigh at the hip and helps stabilize the hip joint. It also laterally rotates the extended thigh.
Because of its close relationship with the sciatic nerve, it may compress or irritate the nerve, causing pain and numbness in the buttocks, hip, or upper leg, a condition called Piriformis Syndrome. This is most common in athletes such as cyclists.
The superior gemellus lies immediately below the sciatic nerve. It arises from the spine of the ischium. It is innervated by the nerve to obturator internus. The obturator internus originates from the pelvic aspect of the obturator membrane and the pelvic bones surrounding the obturator foramen. Innervation is by the nerve to the obturator internus L5 and S1. The inferior gemellus arises from the ischial tuberosity. It is innervated by the nerve to quadratus femoris. All three muscles together called triceps coxae insert on the medial aspect of the greater trochanter of the femur. All three muscles laterally rotate the extended thigh and abduct the flexed thigh at the hip. They also steady the femoral head in the acetabulum. The quadratus femoris originates from the lateral border of the ischial tuberosity, inserts on the quadrate tubercle, intertrochanteric crest of the femur. It rotates the thigh laterally, and it is innervated by the nerve to the quadratus femoris. The greater sciatic foramen, the lesser sciatic foramen. What anatomical structures pass through these two foramina? The structures that pass through the greater sciatic foramen, the piriformis muscle. With the piriformis as a reference, above piriformis lies the superior gluteal nerve and vessels. Below it lies the inferior gluteal nerve and vessels. Other structures below the piriformis include the sciatic nerve, which is the largest nerve in the body. Running closely medial to the sciatic nerve is the posterior femoral cutaneous nerve. The pudendal nerve, which may be intertwined with internal pudendal vessels. Nerve to obturator internus. Nerve to quadratus femoris. The following structures pass through the lesser sciatic foramen. Pudendal nerve. Internal pudendal vessels. Nerve to obturator internus. Tendon of obturator internus.
In summary, the gluteal region is heavily loaded with abundant fat, muscles, nerves, and vessels that are of importance to our day-to-day activities. Watch out for our YouTube shorts for more emphasis, questions, and answers.
Anatomy is the foundation of medicine. Kindly subscribe, like, share, and turn on your notification button.